Hi, everyone. If our panelists are ready, we will begin. Thank you all for being here today and for attending our webinar. Our webinar this afternoon coincides with International Migrants Day, which aims to raise awareness about the challenges and difficulties to international migration. Our panelists today, Ms. Lisa Morris and Dr. Fuad Fuad, work with our refugee health program in different capacities, and they will explore the theme of forced migration through the projects that we collaborate on under GHI's refugee health program. We can start with our first speaker, Lisa Morris. Lisa Morris is Learning Advisor at the Humanitarian Leadership Academy, which is part of Save the Children UK. She leads the Academy's Learning Design Service, where she works with partner organizations to design and deliver learning solutions. These meet a range of humanitarian learning needs. Lisa emphasizes social learning in her approach and has run co-creation projects and facilitated collaboration across platforms and region. She works closely with JHI on our COVID refugee support program funded through the HLA, and I will give her the floor now. Thank you so much for being here, Lisa.
Jasmine, thank you for the generous introduction. It's great to be here, and thank you to everyone for joining on a Friday afternoon in Lebanon. So well done for arriving. I will share my screen. I will try not to go overboard with PowerPoint today for you, but I do find it useful to have a few visual aids. So as Jasmine said, I work for the Humanitarian Leadership Academy, part of Save the Children UK. And we've been collaborating on a really exciting project with AUB and GHI around refugee information, getting access through mobile learning to refugee communities in Lebanon. I want to introduce this project for you, and then really just pull out a few of the key things which I think are quite exceptional, quite exciting about this project before really opening the space back to Jasmine and back to everyone on the webinar today. So I'll try not to go into too much detail about the learning project itself, even though I am super excited about it, but hopefully share just enough detail to give you a sense of how much the team have done over the last few months and how engaged the Syrian refugee community in Lebanon really have been on this. So to introduce the background of this project, it's been a partnership that has benefited from seed funding from Save the Children Denmark. And then with us, the Academy, as the kind of middle partner, we have really a mission to test out different learning solutions in different humanitarian contexts to really see how we can effectively reach the most marginalized communities with really critical information, learning, and knowledge. And in this case, that information is about COVID-19. Now, we had the opportunity to partner with AUB and GUHI on a really exciting project, which I'm talking about here, which is to establish and support a community-based network of Syrian refugee women by equipping them with contextualized and evidence-based information on COVID-19. Now, that sounds quite wordy and quite complex, so I want to break it down. And what it really is, this low-tech learning solution, it's as low-tech as it gets. We have one central WhatsApp group. And in this WhatsApp group, there is a community of community health workers, a network of community health workers, 27 to be exact, all of who are female, who are trained through GHI, and who are also coming from the Syrian refugee community. Within that central WhatsApp group, there are also GHI health experts and project admin. And what happens in this WhatsApp group is on a weekly basis, content and information is shared about a weekly COVID-19 topic. Now, this curriculum had been set at the very beginning of this project, but it's also been adapted and responding to questions and information from the community as the project has gone along. Now, we've been really careful to make sure that the input in this group has been super accessible. So there's no kind of long technical wording, there's no long amounts of text. It's short videos, animations, subtitles, infographics, and then links back to really established sources on COVID-19 to make sure that people have access to that important information as and when they need it. And a couple of quite unique things about this group is that the community health workers are able to bring questions to raise with the global, the GHI experts. So questions are raised within this group, which the community health workers then have an opportunity and a responsibility to share back to their community group. So there is actually a weekly Q&A where the community health workers can interact with the health experts and raise any of the questions that they've been facing about COVID-19. Now that's sort of the first stage, and that's really the sort of central group where it all happens, a very simple WhatsApp group with 27 health workers and some health experts and some project admin. And that's an example of one of the graphics, so a very kind of standardized fixed graphic which can easily be shared, easily be captured, not a large amount of text. It doesn't take up a large amount of data. So this is an example of one of the graphics which is typically shared in the learner group. But then this is where I think it gets really exciting. Now, each of these community health workers are then encouraged to set up their own learner group where they are the admin. And in that group, they invite members of the Syrian refugee community who they are connected to, also women. So this is quite a unique non-expert led group where discussion can be quite open, and the refugee women who are part of this group are really encouraged to engage with the content which the community health worker is sharing, forwarding on from their main group, but also digesting it, so breaking it down for the community and really discussing it in more detail. So you have the weekly input from the community health worker, but you also have what's really critical, the opportunity for participation and discussion in a very non-hierarchical, inclusive forum. So there's opportunity for discussion around the topics which are set each week on COVID-19. And really importantly, there is accountability and responsiveness. So the community health worker brings those questions from the refugee community, which are raised in this group, brings those questions back to the global health experts, which are in the central group. And a week later, when there's that weekly Q&A, is able to respond back within their own learner group. So there's that accountability. When questions are raised, they are answered. And obviously those questions are really relevant to the time and to the situation that these women are facing. And again, this is another of the graphics, an example of one of the short videos which is shared with very accessible and clear graphics. It can be easily shared onwards, it can be easily saved on your phone. So we encourage the kind of accessible use of media and graphics throughout. But then this is where I think it actually gets even more exciting. So from that central WhatsApp group, which has the health experts and the AUB admin and the community health workers, through the learner group, where the community health worker has invited women from the Syrian refugee community, each of these groups, 27 of them. And then each person within that group has then been encouraged to share their information onwards. Now, we don't know how many times each graphic has been shared onwards or how many conversations have been had based on the COVID-19 information which has been generated from GHI as part of that central group. But we have some data to say that there's already been approximately 2,000 people who've been engaged in some of the content around COVID-19 that's been generated as part of this project. Now, I won't talk for much longer, but there's a few really kind of critical things that I want to emphasize about this project, why it stands out. And I think the first one is about accessibility. It's been designed to be deliberately accessible to people with very low access to tech. We've made the graphics as accessible as possible with clear language, low data sort of usage, and fixed graphics that can easily be copied and shared onwards. The choice of app, we knew that many people were already using WhatsApp. So this is the idea of meeting them where they are, rather than asking them to use another platform, and also avoiding the cost of international SMS. The content has been made deliberately accessible. There is no technical language in there. It's really been adapted for the community and their needs at this point. And obviously there's the accessibility of the learner group themselves. This is a very safe space where they can discuss a lot of their questions and concerns without having a kind of hierarchical structure of knowledge within those learning groups. Participation is also really critical to the success of this project. and that is the participation of the refugee women within those learner groups themselves. So when we want questions to be raised, and we want to be accountable to make sure those questions are answered. We've also seen that these women have the opportunity to influence content. They have raised that they would like to see more on specific COVID-19 topics, for example, COVID-19 and back to school, COVID-19 and travel, which GHI has been able to respond to. So adapting content very quickly to respond to the specific needs of the community at that time. And then, of course, they have a choice over how to engage. They're not going to get kicked out of the WhatsApp group if they don't reply or they don't engage in a discussion. So we know that there's been different levels of involvement in the groups. They might have chosen to read and forward on, or they might have chosen to type in their questions or even record something in terms of a response. So there's a choice over how to engage. There's not necessarily a fixed structure that they have to conform to. And lastly, the last point here, which is really critical for Save the Children UK and for the Academy, is about localization. We wanted to know how much could be done in country. And AUB, GHI have really proved just how much can be done within the country. So it's been a super low-tech setup. So it really just involved setting up a WhatsApp group and onboarding the community health workers. I think it took a day. The value of localization, so having a local team who've been absolutely, leading with this project, is that content has been super relevant and super responsive. So when there was the Beirut blast, GHI were able to adapt content very quickly to address that situation at the same time. And then one of the big kind of takeaways, I think, from this project is that the learning community within each of these WhatsApp groups actually mirrors a real life community, which has been lacking over the last few months with COVID-19. So it's really got an established feel of a very safe space for sharing, asking questions, and people who are going through similar experiences. So actually establishing a very localized community group through the form of WhatsApp. Now, I don't just want you to take my word for it. This is some of the midpoint feedback from the community health workers themselves, where they said, all of them, and I didn't just choose the most positive data, but we had incredibly positive data coming back from a lot of the questions that we asked them. And one was about that empowerment, about how able they are to disseminate information back to their communities, and they all said, yes, we absolutely are able to do this. The language is accessible, the content is practical and easy to apply. And actually learning through mobile phone didn't make it more difficult than something like face-to-face, something like an online course, and that ultimately they are walking away with improved knowledge and skills about COVID-19 and also about supporting a community, learning community, through the experience of fostering this WhatsApp learning community course. Now, I just want to wrap up, and I really want to leave as much space as possible for our other speakers and also to hear from participants with any potential questions. But just to give an indication of what's next. So this is a 4-month pilot that we're working on with AUB GHI, and the content itself will wrap up at the end of December. So at the beginning of next year, we'll be working hard on recommendations and next steps, and also producing a toolkit about if you are a humanitarian, if you are a learning provider, and you're thinking about how to maybe go about delivering mobile learning. We've got a toolkit in the works, which talks through some of the really critical steps, whether it's content adaptation and contextualization, or choosing your learner group and your platform correctly. But lastly, just to wrap up, some of the feedback from the community health workers, again, from that midpoint survey, 100% would recommend this course to their colleague or friend, and 78%, so nearly 4/5, would take another course on a mobile device. So we see this pilot as really something which we can hopefully build on in the new year and beyond. So I think that's everything at this stage, and I'll stop sharing my screen. I hope that's been valuable information, and I'll hand it back to Jasmine at GHI.
Thank you so much, Lisa. I think this project proves that really, even in some of the most difficult times to reach these communities, that simplicity is really key in our approaches. The participatory aspect of it is also enriching as well. And moving from that point, I would like to invite Wad Sleem, who is our project coordinator and works on the field with these women. to give maybe some insights about her experience. Wad, if you could jump in for a couple minutes, we would really value your input.
Thank you so much, Jasmine. Hello, everyone. I am Wad Slim from the Global Health Institute. I'm the project coordinator on the COVID-19 Refugee Support Program. Thank you so much, Lisa, for this presentation. It's really clear. It sums up the entire project. I would like to share with you some testimonials from the community health workers who were in the major WhatsApp group. They provided us. We asked them a few questions, and they provided us with the testimonials regarding their experience on this project. One of them told us that it is so unfortunate that they have been busy securing their livelihood. They weren't able to focus on knowing more about the risks of COVID-19. This project, this WhatsApp group, has been really helpful for them. They were provided with all of these information in such simple and practical way. It was easy for them to follow, and it didn't take much of their time. Another one told us that it was very important for her that we provided these information. These information has been like a WhatsApp course for them. The information was useful, and it included the COVID-19 awareness for all ages, and it corrected many misconceptions and false information that people within these communities had. We've also been receiving many requests from these community health workers to provide them with more and more WhatsApp courses on topics other than COVID-19 as well. So all in all, we are really happy that we were able to help these communities, and we are looking forward for expanding our work with them.
Thank you so much, Wad. Thank you for your input. I'd like to encourage our group of attendees to type any questions they may have for Lisa or for Wad or for our upcoming speaker in our Q&A section, and we can address them after Dr. Fuad's presentation. So if I may introduce Dr. Fuad. Dr. Fuad is the co-director of our refugee health program and also leads on the Institute's Political Economy of Health and Conflict workstream. He is an associate professor of public health practice at the Faculty of Health Sciences at the American University of Beirut, and his research mostly focuses on forcibly displaced populations, the Syrian refugee crisis, as well as the impact of this crisis on the health and well-being of the Syrian population. He has served as a commissioner in 2 Lancet commissions, namely the UCL Lancet Commission on Migration and Health. Dr. Fuad, the floor is yours. Thank you for being here.
Well, thank you, Jasmine. Thanks a lot. And thank you for inviting me to join Lisa in this panel and this webinar. To admit, actually, I was listening carefully to Lisa and enjoyed actually listening to this such a very interesting project. And I wish I could spend my time listening more than talking. But let me share just another experience that GHI is part of it in responding to the issue of forced migration, not just in the region, but also globally. Just to share now my screen, if I know how to do that. I guess so. Is it clear now?
Yes, Dr. Fuad, we can see your screen.
Okay, thank you very much. So we're talking about another project, which is a bit different from what Lisa mentioned. Here we're talking about big questions, and that sometimes could be quite strange when talking about the very old issue, which is migration, forced migration, and still we have big questions to answer too. And for this, actually, it responds to a request by World Bank, a group of academic institutes, including Columbia, Brandeis, Georgetown, Los Andes in Colombia, and AUB GHI responded to that in collaboration with UK Aid and UNHCR to set such a sort of answers to these big questions, to try to answer to these big questions raised by the World Bank. Let me first, before going to these questions, try to put sort of background to set this sort of why we still have big questions. As you know, by 2020 still we have this historical level globally about the people that forcibly left their origin countries or settings. We're talking about 80 million, refugees and internally displaced population, asylum seekers, stateless, that, now, moved, resettled, left, or even living in camps in many countries, but 55% are in low and middle income countries. But it's not just the number, it's about also the time. Crisis and this sort of forced migration become more and more longer. We're talking about protracted crises, and the average years now of this sort of displacement is almost 37 years, which put a big question about how those could be served. I mean, in terms of their not just basic needs, but also for the long term. And because we're talking about 55% of them are in low and middle income countries, so you can imagine that many of those left and leave and settled now in fragile and some dysfunctional health systems. Many trial, and meetings and discussions convened in globally, and the last one was a global compact on refugees, was held early this year. I think it was last year, 19. Just to address or to meet the SDG goals, raised by the UN in 15, in this sort of spirit of universal health coverage, trying to address exactly what do we mean by universal, and to be real universal health coverage. So, as WHO put it, in health for all, but by all also. And also to test a new and innovative approach to address the health needs of the forced displaced population. Not just those people, but also the most vulnerable hosting population that needs almost equal needs like the refugees and displaced population. So what are the challenges? There are many challenges. We're talking about, difficulties to address, their needs, and when we have sort of sometimes a very complex and sort of pluralistic environment that put individuals, families, and even big communities in difficulties to navigate and meet their health needs. Just one example, you all know about that. Just in 1 year, last year in Lebanon, that host the highest per capita of refugees in one country as a sort of long-term crisis. They also faced economic difficulties, political instabilities, COVID crisis, and I hope lastly, the Beirut explosion, the big explosion that put all this the country on the verge of collapse. So the big question is how to respond to this complexity, instability, armed conflict, refugees, displaced population, economic difficulties. Usually, and as you may know, that the response to such a sort of forced migration movement or crisis, passed through two different phases. One is the acute phase or the immediate response, that in many cases led to a sort of creating parallel systems. As you know, in many cases, we have the national health system that serve the citizens, the nationals. Then you have like a big group of population that move, and international organization, jump in to serve, creating sort of such a parallel system. And when these become like a more protracted, this parallel system become, more and more non-functional well. And in many settings, we have more than even 2 parallel systems. We're talking about 3 or 4 sometimes parallel system, including informal health system. So this is what usually happen in when the crisis become more protracted. And the question will be in how to address the humanitarian need, how to shape the humanitarian need, while also thinking about the development support, which is usually the big question. So the other issue is about how to finance this sort of health response, given the unpredictable and not well integrated with the national financing system. And when the crisis become protracted, or the response become in a parallel system, that means thinking about how to integrate that is another. Integrate that in the national system is another big question that need to be addressed. But even more, so what are the priorities, when addressing these, multiple needs and for multiple group of population at the same time. So prioritizing the, intervention could be also another big question. So for this, World Bank, raised this issue and asked to address the big question about how to identify, or what are the health challenge that arise in protracted displacement crisis, and what are the opportunities and strategies to build and finance more resilient health system. It could be an old question, but it seems this question is still a big question when talking about the challenges and opportunities and how to make health systems resilient enough. But it's not about how and what, but in a way to be more comprehensive and effective to address the need to the population of refugees and displacement, but also to the host communities. So this research actually is guided by the need to provide practical programming and policy guidance. So it's not just for the sake of research, and also assist the prioritization for the decision making. The main 5 questions on this project are: what are the demographic features and the burden of disease for forcibly displaced population in these studied countries, which is 4 countries, and how does this vary? I'm talking about these features, demographic features, from the host communities and non-displaced population. And not just that, but also with the features or with the demographic features of those group of population, displacement and refugees, with their feature at the baseline when they were in their original settings. The second question is how is relevant the data, the demographic, epidemiological and economic, demographic and monitoring data gathered and coordinated? And how does it, elucidate differentials in health care access between displaced and host population? The third question is how the health system respond to immediate but also to long-term needs of displaced population, given that these, as mentioned, this will be a long-term. And we don't have any clear evidence that many by time return to their original places. And if this is the situation, how the healthcare utilization and the cost spending vary between host and displaced population, and how that changed by time. And we have examples from different countries that during the acute phase, the response, the financial system, it changed by time to differ completely from the starting point. The last question is how has the health financing system responded to the needs of displaced population, and how could it improve? So the countries, the four countries that are part of this big project and big questions are Bangladesh to address the Rohingya refugees' needs there, talking about mainly on Cox's Bazar, in Colombia country, and to address the Venezuelan migrants and refugees. DRC and the many refugees that moved from neighboring countries, including also the internally displaced population, and Jordan to address the needs of and understand the needs of Syrian migrants and refugees in Jordan. The main outcome is to have the demographic and disease profile and to better articulate the challenge and entry point for effective health system and interventions. Well, the project will try to have a sort of standardized, as far as possible across all four countries. So although we will focus on some specific needs and some specific sort of approach, but also we need to find from the big picture, so how to standardize that in a way to deliver sort of general lessons, and also that will allow to explore the complexity of each of these contexts, but within also the big picture. What happened up till now, we didn't start collecting data yet. We did some sort of desk review, and we issued 6 knowledge brief to the World Bank. Given the current situation of COVID and difficulties of movement, there was sort of delay in collecting data. Hopefully, we will start by February to do some sort of field work. And thank you very much. Happy to receive any question. And sorry if I took too many times. Thank you.
Thank you so much, Dr. Fuad, for your intervention. I think it is timely to address how these projects are going to adapt in light of the year that we've had. We will address this a little more in our Q&A. My first question is for you, Lisa. COVID-19 has had to challenge the way organizations function at every level. We've moved online a lot. We have had to adopt low-tech options, as well as be creative in how we reach hard-to-reach communities. So moving from this point and the success of this project in particular, the way it correlates and it joins between low-tech and participatory action, to what extent do you think this serves as a model for later projects? And do you think the HLA will be adopting this model in projects in the future, even beyond times of COVID? To what extent do you think this will help you reach even populations in the region and in hard to reach places?
Thank you so much, Jasmine, and thank you, Dr. Fouad, for a really interesting presentation and what is at the very beginning of a very exciting project as well. In answer to your question, it's a big question, Jasmine, about how we've sort of adapted and tested some of these low-tech learning options under quite challenging conditions, obviously with COVID-19, with remote-based working. But I think you're absolutely right. One thing that's really coming out is that as soon as, you know, all being well, when COVID-19 does pass and we are able to meet together and to learn together as a community again, I don't foresee that this type of learning will be then forgotten. I think we have tested it under extremely challenging circumstances, and now we're looking at opportunities to integrate it going forward. So that might be that there is a face-to-face opportunity for learning and there is a WhatsApp group to follow up, or it might be that people have access to different community-based activities, and then that is sustained through some of these learner groups. So I think there's definitely the opportunity to continue using things like mobile learning, not just because of the current challenging conditions. And when we're talking about our commitment really to reaching the most marginalized populations with access to critical information, critical knowledge, critical learning, it's because we recognize how much opportunity there is when marginalized communities are really brought on board with learning and are really engaged with an opportunity to participate, how much richer the learning can be. As we've seen in this project, the questions coming back are so much more than we could have anticipated in terms of building a curriculum without that level of engagement. So there is huge value in testing out the margins, I suppose, of this type of learning, how it can reach people. We do recognize that there is still a reliance on some level of tech. You know, WhatsApp would still require people to have access to a smartphone, people to have access to data, people to have enough space on a phone to have a WhatsApp group, and people to have enough digital literacy to engage in one of these groups. They also need things like cell phone battery. So it's not entirely accessible, it's not entirely free. And what we have found in some communities is that ownership of mobile phones is often with the head of the household, who might be a male. So actually if we're really looking at each specific group, we need to ask, what does marginalized mean in that community? And how can we design something to overcome those specific barriers? So there's also things like audio recordings, which can be, there's fantastic opportunities with things like WhatsApp where you can do voice recordings. So for people that might not be tech literate or be able to read in the language of learning, they might be able to access an audio recording instead, which can also be forwarded on to their friends, their community, their family. So I think we want to continue to test out types of accessibility with an awareness of and a sort of feedback loop coming from different communities about potential barriers, but really recognizing that the ground that's been broken, I think, in this project with GHI is really just the start of something very exciting. And we're already hearing feedback from the community health workers and the group themselves, the communities who have been involved in these learning groups, as Wahid said, that they're asking for more. They're saying, what's next? So we see that this is not just COVID specific, they're actually building communities, there's engagement and there's interest in this type of information and this learning. So we see, I think, huge opportunity for it to continue going forward.
Thank you so much, Lisa. I think we will all look back on the year of COVID in a while from now and really see to what extent it shifted the way we work at a humanitarian level, the way responses are active and the way projects are actually developed. And I think what's fascinating about this panel in particular is that we are discussing two projects, one that was kind of in reaction and in response to COVID, and one that was kind of hit with a curveball of COVID halfway through the mandate of the project. So if I can ask Dr. Fouad, ask you a question. This project, of course, was initially planned as a long-term project without having foreseen something like COVID. The project now at this level adds a new layer of complexity to an already very complicated situation. You talk about the complexities in forced migration and health and that intersection, and now we are adding a layer of accessibility that we no longer have, a layer of complexity and accessibility. So I wanted to ask, to what extent do you think this project will integrate this COVID component, because it is already at an advanced stage? And my second question is, how do you think that this COVID curveball per se has impacted the way we foresee our contingency plans and the proposals that we will write in the future? No one could have foreseen something like this. Who is to say that in a few years we won't, be encountering something else that would hinder our project in this way? So I'd love to hear your insights on that. Thank you so much.
Thank you, Jasmine. This is an interesting question. Actually, COVID, well, tell us something not new for the region, but for many similar parts in the world. That when talking about a crisis or even protracted crisis, we're talking about a context more than just a sort of peak and at some specific moment of time. So we're talking about sort of long-term, context that, counter different sort of stressors and shocks. Yes, this is what it wasn't in the plan, the original plan, when start talking about the issue of forced migration and to address their needs in these completely different settings, although they are, the main common factor is they are all fragile settings. But even though, no one expected that time to have something also global and not just regional, global, that hit the globe and change also again or add layer to this complexity, as you've mentioned. So that put us in this mood of the way how to expect always that, our work, our research, our approach, our sort of response should be flexible and able to change sometimes even the course in response to the new crisis or shock. And that's what happened actually in this course. And that will happen maybe later in any other context when you have, I don't know, sometimes pandemic like that, sometimes like a sort of a suddenly armed conflict or political instability or, a deep collapse of economy. So how to address that while you keep working on what we called it normal situation to address the already people needs that people want to have. So what to do? I think the main lesson learned is we need always to be flexible. We need to develop our tools to be able to address quickly. We cannot keep working with the same mentality of a long-term research mood. We need to have more, to be more responsive to people's needs in a way that not just engage them in the research outcome, but also engaging them in the research question itself, and also to have more sort of research and translation at the same time, at what could be called the operational research or a sort of research for solutions. So more practical to translate our work into practices, but also to have the needs, the actual needs of population as sort of a main subject for academic research. I see COVID, while it's a very difficult situation, but I see it, to be honest, it's another opportunity to think about how to address a shock, a severe shock, when we are already in a sort of a chronic stressors and shocks. I will stop here. Over to you.
And thank you, Dr. Fuad. I know that being already in a state of shock and instability does not contribute at all to the situation. Lebanon is a clear example of that, where hit after hit has really hindered a lot of our work, which is why when you hear of success stories like the CRSP and working with women on the ground, it's quite inspiring to see that you can really work no matter what the circumstances are. Lisa, if I may close off with you with a final question. To what extent do you think this project is a pilot for something larger? Have you discussed the future of the project, and what are your expectations from the project as it concludes?
Thanks so much, Jasmine. Scalability is forever at the back of our minds when we are testing small solutions. We want to test them on a small scale. So if there are issues, we can identify and adapt quickly and learn from them, always with the intention of scalability, recognizing the potential impact that the learning can have when it's shared exponentially, potentially, as you've seen with some of those learner groups. The specific extent to which this pilot is planning to be scaled is definitely a conversation that I look forward to having in the new year when we wrap up the course itself. But certainly what we're taking away from this specific project is, number one, a super engaged cohort, a super engaged participant group who we strongly encourage to continue to share their learning, their assets, and their way of engaging onwards. So we see that we have now this fantastic group of participants, the community health workers themselves, but also the participants from that, from each of those learner groups, the female Syrian refugee women themselves, that we see as kind of having a life cycle beyond the actual course wrap up. And what we also have is a framework for setting up a learning project in a very rapid, short space of time, which we actually know we can get off the ground pretty quickly. And we know the steps to actually really make it successful. So whether it's this project specifically or another project with this community or with this organization, we know that there is a lot of potential for using this learning in 2021 and beyond.
Thank you very much. I think it's very important for these women and the communities that we work with to feel like they are part of the study and part of the process, and not so much as being studied, which I think is pivotal to what we do. I'd like to wrap up with both of you. Thank you both so much for your time. Thank you for the people that attended in the middle of their workday. For people that couldn't, or if you know anyone that would like to watch this webinar at a later time, it'll be available on our Global Health Institute YouTube channel for anyone to watch. And I think we can close here. I'd like to thank Waad as well for intervening to support Lisa's presentation, and thank you, Dr. Fuad, for also being available on such short notice. Lisa, thank you for everything that you do as well. I hope you all have a nice afternoon.
Thank you all. Thanks a lot. Thank you, Lisa. Bye-bye.
Thank you, Jasmine, for organizing, and thank you to everyone for attending. Bye.
Thank you. Bye.